We're going to talk about Lichen planus, but before we do, let's spend a few minutes just talking in general about diseases that affect the mucous membranes in the skin. There may be involvement that happens at the same time, or sometimes one area is involved and then another is involved later on. Most of the conditions that we cover that are mucocutaneous in nature are mediated by the immune system. Many of them are chronic, and they often are characterized by having acute exacerbations that are symptomatic and require treatment. In terms of the clinical findings suggestive of a mucocutaneous condition, generally we're looking for and can't find any local inciting agents or aggravating agents. These conditions tend to be persistent, they often progress, and again, they do have their tendency to flare up from time to time. They're characterized by lesions that are widely distributed in one anatomic location or in multiple anatomic locations, including oral, skin, perhaps other mucous membranes as well. The types of lesions that we describe when we encounter these mucocutaneous diseases include disruptions in the surface, ulcers, erosions, sometimes blistering lesions, vesicles, bulli. Sometimes the mucosa becomes quite thin. This also happens on the skin. And then we have varying amounts of hyperkeratosis. Little pinpoint lesions would be papules. More broad lesions would be plaques. And of course, lesions that are pigmented and flat are referred to as macules. Because the mucocutaneous diseases are so diverse, it's unfortunate that many of them do have very similar clinical features. And that's why arriving at a diagnosis that is accurate is very important, and it's also quite challenging. So we have to develop discipline and a systematic approach when we're faced with the possibility of diagnosing a mucocutaneous disease. And of course, the more accurate the diagnosis, the better the disease management is going to be. So now let's talk specifically about Lichen planus. Lichen planus is considered a systemic condition. It is mucocutaneous, and it is mediated by the T cells. It tends to occur in more than one location, and it can involve skin plus any one of several combinations of mucous membranes or mucous membranes only. The cause of Lichen planus is not very clear. However, we do know that it's an immune-mediated process, and we know that there is an immune-mediated attack on epidermal or epithelial basal cells, which releases cytokines and recruits T cells and then produces a cytotoxic effect on the basal cells that break them down. So why do we call this Lichen planus? Well, lichens are scaly plants. Everybody has seen them when they take a walk in the woods or sit on a bench outside. They look like little scales on a tree trunk or on the rocks. So, Lichen planus lesions on the skin are going to be characterized by scaly change. Usually the scales are tiny pinpoint papules that become confluent, and they have a kind of a reddish, or we often say violaceous or light purple background. Oftentimes, patients will present with very intense itching. So pruritus is a very, very common symptom with cutaneous Lichen planus. And other areas can be involved, including hair shafts, the nails, and often after a long-term bout with Lichen planus and a lot of scratching of an itchy lesion, we get residual post-inflammatory hyperpigmentation in areas where the lesions were active. These are just some nice examples of the papules that become confluent in cutaneous Lichen planus, and as you can see, there is a slightly erythematous or violaceous background. Of course, some of these lesions have become excoriated from scratching, so we see a little pinpoint ulceration there as well. Other sites of involvement of Lichen planus include the mucous membranes. So any one or several mucous membranes can be involved, and we're going to talk specifically about oral mucosa. And also, there is very frequently involvement of the vermilion border of the lips. Now, what are some of the characteristic features of oral Lichen planus? Well, first and foremost, it's a chronic condition, so patients are not going to have an acute, one-time presentation. It tends to be a disease of adults. It seems to favor women, but we've certainly seen our share of it in men. And one of the most characteristic findings in terms of oral lichen planus is that the lesions are distributed bilaterally. If you have an isolated lesion, it is unlikely that you're dealing with lichen planus. The most common sites of presentation are the buccal mucosa and the gingiva, but any other areas in the oral cavity can be affected. Generally, patients will present with long periods of stability. They're not symptomatic, and every once in a while they'll come in because they're experiencing an exacerbation. But the symptoms in this condition tend to go up and down. So sometimes patients are very comfortable, and other times they develop discomfort that really does require some intervention. We also can encounter lesions that are quite varied in their appearance. Sometimes there are areas that are white and papular. Other times there may be a dominance of lesions that are ulcerative or atrophic. We do know that this is indeed an immune-mediated condition, and in many patients, they'll say that they get their flare-ups whenever they're really stressed out. So anytime you have a chronic condition, we always want to build into our management strategy clinical follow-up at regular intervals. The characteristic lesions of oral lichen planus look very much like a latticework or a spider web. So look for that when I show you some of these clinical photographs. We often describe the lesions as lacy or striated and typically white. So here are some nice examples, and notice that this is bilateral on the buccal mucosa, and undoubtedly the patient probably has lesions elsewhere in the mouth, if not also on the skin, and perhaps other mucous membranes. Lesions like this are unlikely to be symptomatic because the mucosal surface is actually intact. Other examples of this, nicely demonstrating that lichen planus can also involve the gingiva, and it can also involve other areas aside from buccal mucosa and gingiva. Notice the bilaterality. In terms of the pathogenesis of lichen planus, this is what we know. It seems that somehow the basal cells in the epidermis or the mucosa have become altered in some way, such that the immune system recognizes them as foreign. And specifically, T cells come in and they attack, they actually target these supposedly foreign antigens. So T cells, as lymphocytes, migrate to the epithelial stromal interface, and they attack the basal cells, causing them to break down. We often use the term cytolysis or apoptosis, or sometimes hydropic degeneration. And they break down, and often what will happen in the long run is that the epithelium becomes detached from the underlying stroma. So we start out with CD8 T cells that are cytotoxic. They break down the basal keratinocytes, the basal cells, and then CD4 cells come in. Sometimes antigen-presenting cells get involved in the process as well. But the bottom line is, unlike other immune-mediated processes that can also affect the oral mucosa and skin, lichen planus is a cell-mediated immune condition. And here are just some photomicrographs to demonstrate what a so-called lichenoid infiltrate looks like. It's a band-like infiltrate, it's quite dense, and it occupies the superficial stroma, the lamina propria, and notice that it comes right up and hugs those basal cells. They are the target, they're really the epicenter in this condition. And we can see a nice example of basal cell liquefaction here, where we're not so obfuscated by all the lymphocytes. So basal cell liquefaction, and another reason why lichen planus looks the way it does, it looks white because it's hyperkeratotic. And we often see a compensatory hyperkeratosis, as we see here, on the surface of the squamous epithelium. Here we can see some examples of extensive basal cell cytolysis or apoptosis, and obviously the epithelium is not going to adhere to the underlying tissue when this occurs, and you can get ulceration in lichen planus. So this extensive basal cell destruction can often lead to ulcers that we see clinically, And ulcers or erosions of the oral mucosa are symptomatic, and they do require treatment in many cases. So here are some examples of that. In fact, this is a great example to show you because erosive desquamative lichen planus is often presenting as a gingival problem. So here we see on the gingiva that the patient has very red gingiva. The gingiva are very shiny. They are also very thin, and you may have to look very hard, but you may see some white lacy striations. And certainly on the palatal side of the gingiva, we can see areas of erosion near the posterior teeth, and if we look just near the anterior teeth, you can see that the gingiva has a very delicate, lacy, striated white appearance. Other examples of this, we can see it on the gingiva in the upper jaw in this patient, and in the lower jaw on the lower lower right picture, we can see that there are striations in the buccal vestibule, and notice that the gingiva look quite erythematous and quite atrophic as well. Just some other examples to show atrophy, white striations, erythema, and some ulceration and erosion. The lower right-hand picture was a gentleman who had a great deal of pain in the gingiva. You can see how desquamative it is, how erythematous it is. And if we look around a little bit, we can actually see some nice lacy white striations, and I'll show you them in the next slide. Here they are on his lower vermilion border and labial mucosa. So sometimes we focus on areas that are actually very symptomatic, but we really must look around to see if we can find some more characteristic findings. Now, lichen planus, both on the skin as well as on mucosa, is capable of a so-called Koebner phenomenon, or Koebnerization. That's a response where, in a patient who has lichen planus, if you injure an area, either on the skin or on the oral mucosa, in that area you are likely to develop a lichen planus type lesion. So I'll show you an example of that. So here we have a patient with lichen planus on buccal mucosa, nice area of striations in white. But we look down on the lower right picture and we can see a large area of ulceration with some erythema in the midst of this white change. Obviously, the buccal mucosa is a site or an oral location that is very trauma prone. So it's not surprising that many lesions of lichen planus in the oral cavity actually do occur on the buccal mucosa. I'm going to show you a few examples of instances where we get lichen planus-like lesions. One famous one would be a lichen planus-like reaction to a medication that was recently introduced. So lichenoid drug reactions can follow the introduction of some medications. There's always a long list of those. And very often when you have a lichenoid drug reaction, you're going to find erosive lesions that are usually quite symptomatic. So here's an example. As you can see, this lady has a very, very odd-looking tongue. This is a very painful lesion. She's got a big ulceration, it looks like a map, all across the dorsal surface of her tongue. And she had just received some new medication for her chronic obstructive pulmonary disease. Shortly after she took the medication, within just a few days or perhaps a week, she developed this very, very painful tongue. Now, we look at the tongue and we see the ulcer, but we also need to step back a little bit and look around. So even on the tongue, we can see areas more toward the anterior portion that look like little white starbursts, and toward the back, we see areas where the tongue surface is quite shiny and atrophic and also has some areas of white and red. But if we really step back and take a look all around the mouth, we can see that indeed there are white striated lesions on her upper edentulous ridges and into the buccal mucosa, and also on her lower vermilion border. So there you have a nice example of a lichenoid drug reaction in temporal relationship to the introduction of a new medication. Here's another example. This was a lady who had an explosive lichenoid drug reaction to a new medication she was given for some cardiac issues. Within just a few days of taking the medication, she had an extremely sore mouth, very sore lips, and she was in tremendous pain. We contacted the cardiologist. We asked to have her medication discontinued and perhaps switched to something else. We also put her on some immune modulators systemically, and we saw her back in several weeks, and as you can see in the lower photographs, she is doing much, much better. We can also see lichenoid reactions that come up in some patients, not all thankfully, with direct contact with certain agents such as a new amalgam restoration in some patients. Sometimes it's cinnamon. These are well-documented hypersensitizing agents for some people. And again, these kinds of reactions can also be accompanied by erosive changes that can be quite symptomatic. So here's an example. This patient had a new amalgam restoration placed maybe a few days or perhaps a week before, and after the appointment noticed that there was some considerable discomfort on the left side of their tongue. As you can see, there's a white area, red areas with some probably erosive change, very uncomfortable for the patient. And we can see the patient just a few weeks later after the amalgam was placed, and you start to see that things are starting to fade somewhat and they're feeling considerably better. Now, how do we manage lichen planus or other benign lichen planus-like processes in the oral cavity? Well, this is what we tell our patients. Generally speaking, if you have really classic presentation, where you have nice white striations, there's bilaterality. In other words, if the features are pretty classic, it is not absolutely necessary to do a biopsy. However, if the features do not seem to be particularly classic, it's probably wise to get some biopsies for diagnostic confirmation. We also want to tell the patient about the fact that this is likely to be a long-standing issue for them, because this is a chronic disease, and that they can expect to have flares from time to time. We also need to stress the need for regularly scheduled, ongoing clinical reevaluations, and that's usually either once or twice a year. And of course, if a patient does develop a flare or exacerbation, we urge them to come in right away so that we can give them the appropriate management strategy, usually some sort of therapy to deal with the symptoms and also to see if we can get some erosive lesions cleaned up, depending on the extent and severity of their flare-up. What are the treatment options, basically? We always base them on how bad the disease exacerbation is. If it's quiet, we don't treat them. We just basically keep an eye on them. But if we need to treat them, depending on how severe the exacerbation might be, we often will start out with topical corticosteroids or other non-steroidal immune modulators. If we have to, we can go to topical plus systemic immune modulators, and the primary treatment would be corticosteroids for several weeks at a time. And in some cases, we'll go to topical agents, sometimes with systemic steroids, maybe with other agents that are non-steroidal and adrenal sparing. And of course, there are other immune modulators out there that can be very helpful in some instances. So to wrap it up, basically, we're going to say that lichen planus is a condition that is fundamentally benign, and it's within a spectrum of lichenoid conditions. So lichen planus is the prototype, but there are other lichenoid conditions that can present on the skin as well as other mucous membranes. And of course, in order to diagnose this disease, we have to pay attention to both the clinical as well as the pathological criteria that are fairly strict and that have been laid down.